So, good morning. First, I would like to thank the organizing committee, especially Professor Si Wing, who invited me to participate in this very interesting conference. So, I have 30 minutes to do my job about talking the culture of people with advanced dementia in cultural context. Because dementia is found commonly in older people, but we must know that older people is not just adults with gray hair. They have some unique feature. I can give you some summarized in a mnemonic called RAMS. R stands for reduced body reserve, because normally when people aging, they tend to have cognitive decline, but it doesn't mean that they have dementia. And the second one is A, atypical presentation. Right? This morning, Dr. Nathan told us about the BPSD. And you know, BPSD may be some atypical symptom, like maybe caused by pain, something like that. So we must know that. And M, medical pathology. People with dementia tend to have other diseases as well, such as diabetes, hypertension, something like that, and even osteoporosis. Because of so many diseases, they tend to have the polypharmacy. And you know, very commonly, the drug for dementia also cause adverse drug reaction, especially those with anti-cholinergic drug. And S stands for social adversity. That means social can have impact on the life of people with dementia. So we remember RAMS. And because dementia is, I must call it easier dementia medicine, because it involves so many aspects of the disease. I can give you some. There are three main aspects of the holistic care for people living with dementia. The first one is the cognitive function. There are two interventions. This is the pharmacology and non-pharmacology. Right now, there's no cure by drug for the cognitive function. So far, we have cholinesterase inhibitor. It is just a delayed process and full of adverse reaction. And the second way is non-pharmacological treatment, like cognitive training, cognitive stimulation, like that. And the second aspect is the BPSD. And again, there are pharmacological and non-pharmacological management. And okay, people with BPSD tend to have agitation, psychosis, hallucination. And there are so many drugs, such as quetiapine, risperidone, that we get used to that. But again, lots of adverse drug reactions. So it's the best way to use the non-pharmacological treatment, like environment modification, family caregiver intervention, something like that, that Dr. Nathan just talked to us this morning. But last but not least, general management is really important. That's why I call it dementia medicine, because we have to address about the comorbid disease, such as those with the NCD. And you see, it's such the own topic. It needs maybe 2 hours to talk about this. And the caregiver, we have to be careful that we don't just treat the patient, we have to care for the caregiver as well. And the ADL, that we tend to preserve the ADL of the patient. Environment is a really important thing. Hospice and palliative care, and we will talk about this. And the last one is a legal issue about the asset of the patients. So, for example, just environment, like you can see, we have to design the living environment for people with dementia. Why? Because they need a lot of requirements, such as the environment must be structured. Why? Because it can facilitate the orientation. It can serve as a cue to memory, such as we should use a big wall clock that the dementia patient can see and can orient themselves, and be stable. That means we must not change the structure quite often. And the next one is be familiar. That means we try to use their personal belonging that we used before to support the relative orientation, to support autonomy. And the next one, it should be safety, like provide something that is safe. That means we must not leave some sharp things like knife on the table because it can do harm. And another thing is we have to plan for the wandering because people with dementia tend to do walk around นะครับ run around. So it's not safe that their home or their place is near the river, something like that. And the next one is it should be functionally independent. That means to promote the personal control, opportunity for sensory stimulation and change, avoiding either deprivation or overload of stimulation. And that means we have to provide the opportunity for socialization and at the same time to protect need for their own privacy and to minimize fall. Also, to make environment simple and provide good visual access, because the patient tend to hide things. So if we have so many cupboards in a room, they may hide things that it will get lost. Right. These are some examples of the living environment for people living with dementia. Right. Another issue is palliative care. So I spend much of my time about this. So after my talk, you should know about these 5 aspects. This is why healthcare provider or people need to know palliative medicines, rationale, advantage and disadvantage of the referral, essential palliative care for healthcare provider, and 4 core palliative skill for healthcare provider. Right. The first one, as we know that every year we have a new case of dementia, 10 million worldwide. That means right now the prevalence is about 55 million dementia worldwide. This is the figure from the World Health Organization. But the bad news is 60% of them living in low to middle-income countries like in Thailand. And currently, dementia is the 7th leading cause of death and also the major cause of disability. And as we know, dementia now is just incurable, no cure. Even right now, you may see in the literature that some drugs like donanemab, it is an anti-amyloid drug. It's been tried, but it's still not in the market yet. And dementia is the many source of suffering, like physical, psychological, and spiritual source of suffering. Right. Yesterday, Dr. Nathan told us so many definitions of palliative care, and I do some summary that the common keywords in every definition, they are serious illness at any stage of disease and setting, quality of life such as physical, psychological, social, spiritual. It should be done by interdisciplinary team, and we should focus on the patient, family, and caregiver. So these are the common keywords in every definition of palliative care. So palliative care should be for whom? That means those who have the high risk of mortality, those who suffer from disease that negatively impact their quality of life and function, and being burdensome in symptom and management, and this is caregiver stress. So from these 4 characteristics, we can see that all people living with dementia, not just in advanced case, needs palliative care, because you can see just mild to dementia, then they also fit in with this criteria. Right. In the past, hospice and palliative care has been viewed as a countercultural health program for patients dying with cancer. to get away from the traditional medicines because at that time the anti-cancers were really nasty, really toxic. And at the same time, the doctors tend to give the most advanced medical technology to save life in whatever cost. And you can see in the USA, even in the USA, the hospice benefits start in the year 1982. But in the year 2018, about just half of the Medicare beneficiaries receive hospice care. You can see it's too late to refer to the palliative care. But it's getting better. The figure from last year from the National Hospice and Palliative Care Organization, it showed that the neonatal primary diagnosis have the longest average length of stay in palliative care. Like in this graph, show us that in the past, cancer get a lot, but now Alzheimer's disease and cancer share the same amount of the people who stay in the palliative care. It's about 24% the same. And next one, what is the advantage of palliative care in dementia? That means the patient get a chance to have an ACP to improve the pain and also improve the emotional support, to improve communication between patient and physician. And that means they can access to the early use of hospice rather than in the last few days. And shorter length of stay in ICU, because in ICU is the worst place in hospital that the older people tend to have delirium. And also improved care in associated chronic disease such as congestive heart failure. And we can see the slide from Dr. Nathan yesterday that it can improve survival of cancer case also in dementia, and also improve caregiver satisfaction, lower healthcare costs, and improve quality of life in many aspects. What about the disadvantage? If there is a delay in the referral to the palliative care, and we can see that it can cause the suboptimal symptom management, increased suffering, less advanced care plan, and more hospitalization and unplanned hospital death. So these are so many disadvantages if there is a delay. Right. The next one, I will talk to you about the 8 domains of palliative care delivery. That means, first of all, we have to design and collect a teamwork, such as a physician, nurse, chaplain, social worker, pharmacist, family caregiver, to do the assessment and care plan. And we also do deal with the care in the physical aspects, such as symptom control, mental care to support in the situation of grief, depression, and anxiety. And also we have to support the social care. The next one is the spiritual care. As you can see, there is a lot of needs for patients in terms of spiritual, religious, and existential needs to cope for the spiritual suffering, loss of dignity, and depression in people with dementia. And the next one is the cultural aspect. End of life, as ethical and legal. All these 8 domains is really essential in deliver palliative care. Now I might talk about cultural aspect. So the healthcare provider, like all of us, must respect and acknowledge the cultural sensitive issue like the race, ethnicity, social class, religion, spirituality, physical appearance, or even ability of the people with dementia. So we have to deliver the cultural sensitive support to the people with dementia, also the caregiver at the same time. That means all the set environment, policy, procedure, and practice must respect or design according to their cultural belief. Cultural belief, value, traditional practice, language, and communication preference. And the next cultural aspect is the communication. So we should try to use only simplified, not medical term language to the patient, also to the caregiver. And be careful that if we use the preferred pronoun like he or she or they, we have to consult them and use it in our communication and in the document. And what about the cultural aspect during we do the screening and assessment? And we should bear in mind that when we do the assessment, we have to be non-judgmental. We must not judge the patient, to be neutral and beware of the potential bias. And we have to be careful about to assess the cultural practice, belief, value. What about they prefer dying process? What should do in the last hour of life and the post-death? And the next thing is quite difficult for us, especially in Thailand. That means truth telling. So we have to be careful about the preferred cultural practice of the patient and the family, that shall we share or not to share the diagnosis and prognosis to the patient. We have to assess this before doing that. And in the cultural aspect, in terms of treatment, if there is a traditional healer or cultural representative, like their senior in the village, he's involved, that means a request by the caregiver or even by the patients. So we must ensure that they can participate in care planning, discussion. We must not let them out. We have to include them to discuss about this. And when discussing about the diagnosis or prognosis, truth-telling should be respected, prioritizing that we will not lie to the patient. We prioritize the fidelity to the people with dementia. And again, the clinician must try to incorporate palliative care specialists, also the cultural representative, into the care plan. These are the cultural aspects in palliative care for people with dementia. Right. And I will go to another issue, that what are the unique features of palliative care in this situation? The first one is communication. The second one is a prognostic challenge. And the last one is a psychological challenge. So let's go to the communication first. Because people with advanced dementia, they cannot speak or just speak less than 5 words, something like that. So they have some speech impairment. And also they have the cognitive impairment, especially those who have rapidly progressive dementia. That means in this situation, they may retain their motor skill to speak, but they lost their ability to judge, something like that. So it's quite hard to communicate. And also some of them have BPSD, like frontotemporal dementia. In this kind of dementia, the patient tend to have impulsivity, loss of empathy or apathy. And some people with Huntington dementia, you have seen the video clip in the previous session. They're quite young. In that situation, they may suffer from something like genetic cause, like Huntington disease. In Huntington, they suffer from apathy, obsessive compulsive behavior. So all this situation that it may be difficult for us to communicate with the patients. So be careful about this. Right. In the second one, the prognostic challenge. As you may know that in the dementia situation, there are a high degree of uncertainty. In what way? First, the duration of disease may vary between individual, and impact on function again not the same. And some patients will have acute stroke on top of the mild tumor dementia, so it's really uncertain. And also some of them may have delirium on top, so it's quite hard for us to do the prognostication. And right now, there is no universal prognostication tool. It's quite difficult for us to do that. And the very important thing is that the patient needs may change over time. What we said last month, it may not be the same today. So that means we have to assess quite often. Right. The last one, psychosocial challenge. The people tend to have loss of sense of self. Depression. So far, you can see up to 1/5 of people with dementia suffer from major depressive disorder, and up to 50% of vascular dementia will have depression. Another term is delirium superimposed on dementia, or DSD. This is quite often we use this term. From the recent systemic analysis, I reviewed that the poor prevalence of DSD, nearly half of the people with advanced dementia from 81 study. So it's quite common to see in this situation. So the next one, I will tell you about the 4 core palliative skills for healthcare provider: communication, prognostication, symptom management, family and caregiver distress and needs. The first one, what we should to train for this, to whom that we communicate. That means not just the patient, but we have to communicate with families, caregiver, or we may have the surrogate decision maker. And when we communicate, it is quite surprised from the study of Robinson that about nearly 40% of stroke victims during initial hospitalization has ACP before, even they have some kind of vascular dementia. So it's quite difficult to do that. So why we tend to delay the ACP? The first one may be the doctor hesitancy. Why? Because lack of training. You can see the people at the emergency room, the doctors in the general ward, they don't have enough training in this kind of communication, and lack of comfort. So it may feel reluctant, uncomfortable to talking about this issue. And again, because of the lack of prognostication tool, and so they have the prognostic uncertainty. And the last one, because doctor may be concerned that if we talk about this, it can cause adverse after effects on the patient. So that's why doctors tend to reluctant to talk about this. And be careful of sending the wrong message about medical neglect. Why I put this? Because in our healthcare system, we have UC, user health coverage. That means that people can get treatment for free of charge. They don't have to pay anything. So if the doctor come up to say that, shall we talk about ACP, what you should do in a situation like that, and the patient and caregiver may think that, you neglect my parents, something like that. So be careful about this message. And uh, from the some suggestion that so what is the event, the trigger event that we can do the communications, like if we encounter with a patient with recurrent hospitalization or unintentional weight loss, cognitive change, frequent fall, new serious comorbidity, and function decline. So from this event, it's really the best time for us to talk about the ACP. And what are the essential issues about the ACP, about the communications? So first one, we have to assess the patient understanding of the illness. But you must never ever ask the patient that, would you be surprised if this patient die or bedbound within next year? Do not use this sentence, but instead we can ask, what have you heard about your illness? We can start with this question. And then we assess their hopes and worry. Like we can start with the sentence that, what things are you hopeful for the future? What are your biggest worry at the moment and at the near future? Something like that. So this is the general overview of the question. And then explore a bit further as we talk to the patients. And then we assess the decision-making preference, the prognosis, medical goal, and what we should do, and with that, we may know something. And ACP is our ultimate goal to communicate with the patient and the caregiver. And before we do the assessment, first we should go through the medical record and data and to see the profile of the patient. What about their previous illness? What about their belief? What about their background? Something like that. And then trust building is very essential. So when we approach a patient, you express your empathy, express curiosity to help them, and then when they talk, show empathetic listening. We can use the mnemonic calmness as a communication skill, like naming emotion, understanding what patient is communicating, and then respect them both in a verbal and non-verbal manner, and support the expression. And the last one is to explore the patient emotion. So these are some useful skills to start with the communication. And the last time is to provide basic psychological and spiritual support. The second one, the second skill, prognostication. Because of lack of tool, so we must choose that what kind of prognostic information that we should deliver to the patient, like survival, how many years, something like that, how many months, and functionality, about their disability and quality of life. And also, we're looking for the available data to understand overall trajectory before delivering the summary, and tailoring the best available evidence to patient-specific factors. And be careful that we should do the de-biasing to avoid the over-optimistic or pessimistic prediction. It's quite surprised that from the survey, only about 1/4 of the patients prefer not to discuss prognosis. It's quite surprised. So we must careful about this. So we can use the strategy called ask, tell, ask. So ask first, ask what you heard about your prognosis for this disease, something like that. Would it be okay if I tell you about prognosis? So start with this question. And then if they, oh, I don't want to know that, so you should stop about this. But if they, oh yes, it's quite interesting. So we tell them, sharing information that we get to the patient understanding, situation, willingness, something like that. And then ask again to check the message is clearly understood and received by the patient. And then we can move on to do the prognostication. And again, we must never ever breaking the bad news straight away. Oh, uncle, you have a severe dementia, you lose your orbit, something like that. So we can use the very useful mnemonic called SPIKE. S stands for setting up the interview as a formal setting, and to assess the patient perception, and then we have to try to obtain the patient invitation, that the patient invite us, not that we try to influence them. And then if I invited to break the news, and then we give you the knowledge, information to address the patient emotion with empathetic response. And then finally, we formulate strategy and summary about the bad news. Normally, we say, oh, I'm sorry about that. So avoid the term, I'm sorry. But instead, we use the term, I wish, effective in the loss of setting of loss, analytic. Right. The third one is the symptom management, like in the as a neurophysical, non-physical, and is emotional. Some problems of people with dementia that we can see is the delirium. So we have to try to find the cause of delirium, like ADR, the cause of any type of distress or pain as a BPSD, and pain to be under treat, as we know about this morning. Anorexia is normally caused by the drug. So we know that tube feeding is not good. Try to do the comfort feeding. The last one is the family and caregiver distress. As you know, nearly 60%. So the caregiver have a high risk of burnout, like especially those who are female, who live with patient 24 hours a day, financial strain, isolation, low education attainment, and obligation to do the caregiver function. Right. So, in case that we see that the caregiver burn out, we should offer them about the respite care. In respite care, I think I will, because time is up now, sorry about that. But I like the word, no suffering. It works very well when we try to encounter with end-of-life care to ensure that the caregiver. And right now, I think euthanasia is illegal in Thailand. We have to talk about where to stay when the patient dies, something like that, and respectful management to the body of the staff. I come across with a case that a patient died from the severe dementia, and the body has been packed on the stretcher. And the nursing staff put all their personal belongings on the top of the body. So when the relative come to see that, it gives them a shock. So must never do that. Why I show at the end of the last day, in Buddhism, there is no usual agree about the spiritual right. Interestingly, again, different around the world, but in Islam, quite the same. In a dying person will repeat the Shahada, or declaration of faith, as their last utterance. And because Muslims believe in physical resurrection, the cremation is not allowed, so the burial should take place within 24 hours. So we should do it as quick as possible. And the body is positioned facing toward Mecca in Saudi Arabia. Right, so the team is really essential. Patient, caregiver, doctor, nurse, social care worker, pharmacist, cultural representative, dietitian, NGO, community palliative specialist. So all this work in a team for people with advanced dementia. I think I have finished my talk with this slide. Thank you so much.
Thank you so much